Hi, everyone. Welcome to Bari Connected, our podcast that we are now have started and are doing for patients in the bariatric field. So welcome, welcome. We are joined today by Nina. Nina, I'm so happy to have you here.
Me too. Thanks for having me.
Yeah, I've met Nina a couple different times at different events. She's always just such a friendly, happy face, and I just love seeing you because you just bring good energy in as we're doing this. You've been so involved.
I'm sure the same about you.
Yeah. So involved with the bariatric community. And I'm going to kind of talk a little bit about her background. And then I'm going to kind of turn it over to Nina to tell us a little bit more about herself. So Nina is a dietitian that has her PhD and is also a health psychologist and advocate. She has been embedded in the obesity care community. And I'm going to let her go into more details. So many different connections. She's been a dietitian as a program director for the Medical University of South Carolina's Metabolic and Bariatric Surgery Program, where she's worked for 16 years. She's also recently joined seca's Medical Body Composition and Bioimpedance Analysis Division and as the Professional Affiliations and Education Manager. She also is passionate about a patient-centered approach, effective communication and language, and really just improved access. And I know, Nina, you've worked with the ASMBS, I believe, with some of this too as well. Mm-hmm. Leadership positions with the American Society for Metabolic and Bariatric Surgery, which I just mentioned, the weight management group of dietitians for the Academy of Nutrition and Dietetics, and is also on the board of directors for the Obesity Action Coalition. And you'll have to also give us a heads up on everything that they have going on, as far as their upcoming convention. I'm going to be there at the OAC, and I look forward to that. So at that, while you're kind of giving us a little bit more detail about what you're going to be talking about today, and also about your background, I'm going to put myself on mute for just a second, reach over to our Facebook page and say hi to everybody there.
Great. Okay. Well, yeah. Thanks, Brenda. I appreciate being on here and talking to the folks who are listening. I love the bariatric metabolic community, the bigger, obesity care community. That has been my professional home since I moved down south to South Carolina in 2006 or 7. So it's been a long time. I absolutely love this community. I think it's such a supportive place for people to find their people. And so I really do. I definitely have a passion for in-person connections and going to meetings. So yeah, we can definitely talk about the OAC meeting, which is the group, and a patient advocacy group that does support and advocacy work for people with obesity and aiming to get better access to care, reduce bias, and all of that is what I have really found to be my passion as well. So they are having an annual meeting in September, the 21st to the 24th. It's going to be in Orlando at a really nice resort, the Wyndham Wyndham Grand Bonnet. It's really nice. We got to stay there for the board meeting. So one of the things actually that I thought was the most exciting is when I had to check out the spa, of course. And when I went there, they had different sized lockers, or they had lockers and they had different sized robes and shoes and everything. And it was just this really neutral way that she presented it. Like, here's this size and here's that size, and take your pick, but whichever is for you. And so that just was a little nugget of, this is the right place to be. And so, yeah, so come down to that meeting. It's in 2 months. We will also be there. seca, the company that I'm with now, Body Composition Device. We are going to be exhibiting there as well. So come hang out with us there. But yeah, a little bit about me. Brenda, you gave a good introduction. I started as a dietitian. I worked in a bariatric program, the Medical University of South Carolina here in Charleston. And I absolutely loved working with patients as a dietitian. I definitely felt like I needed more skills in the psychology realm. So I actually, during that time, went back to school to get my degree in health psychology, because I really just found behavior change as all your listeners know, to be really hard. And, when I went to school and thought, okay, I'm going to learn everything about nutrition so that I can teach people how to, improve their health through what they're eating, I thought that was going to be not as hard as it was. But, with chronic health conditions that are lifelong, I think we'll talk about that a good bit today. It is a lot more, as you know, than just eating the right things and moving the right amount. It's such a complex condition. And so I really found the skills that I learned in my psychology program to really help me out as a dietitian. So that was not maybe the most financially wise decision, but a degree in psychology and nutrition has really helped me to kind of combine what I'm doing with patients. And after doing that for a while, and I did get my PhD, I decided I loved working with the leadership of our program, and I had so many goals and things I wanted to do. So I became the director of our bariatric program for about 6 years. And that was another, really rewarding way for me to get involved in the insurance and access. I say rewarding now, looking back on it fondly. It was very frustrating at the time because, again, as you guys know, the policies for navigating bariatric surgery are insane and complicated. And I just, it was a very puzzle piece thing for me. I figured out all these ways. And just when I had this perfect algorithm of how to figure it out, insurance policies would change. And so really trying to advocate for figuring out how to make that a little bit simple, a little bit more simple was something I enjoyed. But yeah, I think that was a big part of my kind of connection with advocacy and insurance and navigating that whole thing. So yeah. And then most recently last year, I joined the team at seca. So seca is a company that has been making scales and weighing equipment. So if you've had a baby, you've probably seen our scales. They've been around for 180 years, a German company, and they have had a body composition division for about 12 or 13 years. And I joined them as their kind of clinical person. I work between the professional associations. So some of the groups you mentioned, I still get to stay connected to the bariatric and the nutrition and the obesity groups. I work with them to make sure that we're, knowing what's cutting edge, knowing what's going on in the communities, and that we're responding from a product and an education perspective. And then I also work in educating people who get a device. So, healthcare providers that purchase a body composition analyzer, teach them how to explain the results to their patients. And so that's, kind of the two big things that I work on. It's been another surprise for me to be able to use my psychology in doing that, because the communicating of results to patients, again, just like nutrition, is not just, hey, here's your muscle mass. Hey, here's your body fat. Good luck with that. There's nuanced ways, and something I did recently that I think is a lot of what we'll talk about today is involving the psychology of weighing and how we communicate about weight and BMI and all of that. So I've found a way, I think, to make all of the things that I'm really passionate about kind of come together. So happy to share that with you and your listeners.
Oh my gosh. So much of what you said just kind of resonates because it's, it's endless learning, Nita. I'm kind of like you, endless learner. I just keep, like you just keep tacking on things just because you're so interested in kind of growing, I guess, and always kind of redefining what that looks like. And I think you're like the whole package, being able to, with being immersed in the bariatric field, with being a dietitian and also the health psychology. I've never in my life known anyone who has actually done both of those. I mean, there may be somebody out there. I just never heard of that before. So that's such a unique little
that's my psychodietitian.
Yeah.
That's my Twitter handle. And I think it applies because I do, I am a little crazy,
Well, figuring out life in general, all of us are, there's not an easy route, and just really, I feel like it's really so many things that I've learned. I always thought I'm like very service orientated. And I think you are too, just by listening to your background of all the different things you're involved in. And for me, I always thought, I'm doing this for other people because I just had such a deep desire to learn. But then I really, like, so many of these things benefit us as people to be able to navigate life and to be able to make it like simpler, because it's all about simplicity and being able to kind of, like when you're going under, like a lot of these people who have been through weight loss surgery or who are in the community, maybe thinking about weight loss surgery, a lot of times they maybe have tried a million different things. And when they undergo weight loss surgery, they may see changes, but there's more change than just the weight. And sometimes I think we have to look at like where, like, as you're going to be kind of talking more about the body composition, I'm super interested, because we had a gentleman, we had Kim and Rob last week on. I don't know if you know either one of those people. And they talked about, Kim is a dietitian, and Rob he's a dad, but a bodybuilder. And they talked about, like the foods that you put in and like really being able to see your results in other ways than just the scale. So I'm really interested in seeing how you can incorporate that. I love how one topic just kind of feeds into another.
Yeah. Well, I think, one of the biggest things that we talk about, in weight loss surgery or obesity surgery, or however you want to frame it, is language. And that has become such an interest of mine, because it really does have such an impact, the way we talk about weight, the way we talk about outcomes after surgery. And so, I do think there's change happening in the field. So, I do want to communicate to folks that, there's a lot more energy from the societies working towards a more patient-centered environment, using terms that are appropriate, making sure that, we're all on the same page with how we communicate about this. So we're seeing a change even in the terms bariatric, towards more metabolic, bariatric and metabolic surgery, because it is not just a surgery that affects your weight, right? And weight is one of those words. I think fat is one of those words that it has a meaning as a noun and an adjective, right? But like there's so many nuanced layers to that. And so with weight and weight loss surgery in particular, there's so many more things that it does besides just lose weight. And that it's just such a transforming experience, I think, for people who go through that. And you're changing your body, you're changing the composition of your body. And that is what I'm seeing in the obesity field, moving more towards definitions to better define obesity, even instead of, hopefully people have been hearing a little bit of the buzz about some language changes in the American Medical Association, recommending a move away from using body mass index so much to define obesity. I think patients especially will be happy to know that, because that's a big one. People don't like to be labeled by their disease. And that has been such a ethically charged term. So there's some movement away from the term or from the BMI being the diagnosis of obesity. There's movement towards calling the disease even more like excess adiposity. So adiposity meaning adipose tissue, which is the fat tissue, because that's really when we're drilling down to like what is the body weight. We're not wanting people to lose water and bone and muscle. We're not wanting people to lose that in their weight. But if you're not measuring, what people are losing, then that's kind of been the proxy for, well, you're doing well if you're losing total body weight, because we're hoping that you're losing body fat or adipose tissue. And so I do think it's encouraging that we're moving towards, this is what we're really trying to lose. We don't want to lose muscle. And that's something we can talk about for a while, of how important it is during a weight loss intervention, surgical, medical, nutritional, that you are focused on preserving muscle mass during that weight loss. And how are we going to know if that's happening unless we're assessing it regularly, trending it, measuring it? And so I think for me, it's been a really exciting way to get away from weight and BMI, but moving towards something, because I can see how it's frustrating, right? If we're saying, okay, don't use those terms. Well, insurance is still using those terms. And for how long, right? It's been 10 years since obesity has been classified as a chronic a disease. And so it took a long time for people to even use the codes for BMI to classify obesity. So where do we go from that? If we're not going to just get rid of that as a classification, because it does have a purpose in screening. But I think it's important that we talk to patients too about, what are we moving towards? If we're not going to use that, what can we use, and how can we better measure your change in your body as you are getting healthier? And health condition changes is a big one. And changes in muscle mass, changes in body fat are also big.
So with this, would you say, when you're talking about, why is using the ideal weight, goal weight numbers problematic in defining success and failure? Because sometimes people will, and I know a lot of bariatric programs, including the one I worked at, was probably kind of focused on goals, here's where we want you to be. And now I look back and I think, was that the right way to go about it? How should we have been defining it differently? And of course, the patient's goal plays into mine. But can you tell me maybe what you see as moving towards what that might look like more, as far as defining more what success should look like and what failure should look like?
And that in a nutshell is kind of, it describes all of this, right? So first, I think part of what you said, success and failure, that to me is a language thing that we really need to talk about. So one of the things I like to talk about a lot is black and white thinking. I'm sure you've talked about that on here. It's this tendency that we have to sort of put things, it's easier for our brains to put them in a all or nothing, yes, no, good, bad kind of category. And I think most people I know are sort of black and white thinkers. It's much easier for your brain to sort of say, yes, this is what we're going for. Did I get there? Yes or no, good or bad. So that type of thinking is tricky. And I think success and failure to me also denote that there's a finality or an endpoint to an intervention like surgery in this case. And the reality of really conceptualizing obesity as a chronic disease means there's not an endpoint. It's a lifelong condition that you're working on managing. And so even if your weight stabilizes or your weight puts you in a category that's not obesity category anymore, that doesn't mean you're not still someone who had that disease. And that disease state is something that I think you're always fighting to defend, that tendency to put on excess adiposity or excess body weight. And so when we talk about success and failure, I don't talk about success and failure. I think we talk about, lifelong journey. That's a better way to put it to me. We talk about the outcome being the goal when we talk about weight. So if you're saying, I want to do that, when people even say goal setting, right? So I always would say, my surgeons were really well trained by me at this point. I would say do not give someone a goal weight. That is one way to make me just crazy, because first of all, that's an arbitrary number. We don't know how, someone's going to get there. And there's a lot of power in those words coming from this. There was a very big, I think, power dynamic between the surgeon and the patient, where, they would say this number. And then as the dietitian, I'd spend an hour unraveling all the meaning around ideal weight, desired body weight. This is the weight I want to get to. This is where I was at in college or in high school, or all of these things associated with the weight. And then, hey, we just lost an hour working on the actual stuff that would get you to that. So when you're setting a goal, you don't set the goal of here's what I want to get to. We set the goal of what are the behavioral things that you do every single day that can inch you closer to a movement towards something. And, I think that is a big part of the success failure kind of terminology.
Because you don't have control over exactly where your body ends up. You know what I mean? You have control over the actionable things you do, how much water you drink, how much protein you have. Is that what you're talking about? Is that where you're going towards?
Yeah.
And then that drives people crazy when they don't see the numbers move initially. And then, or I shouldn't say initially, but they don't see the numbers moving.
Yeah.
you
the
know.
biggest thing is and I've seen this happen so many times, and it's really distressing to me as someone who's, I'm their cheerleader, I'm their champion for improving their health, right? So I would see patients who worked really hard on a particular behavior change, and they were mastering it. It takes a long time to really make something a habit, and that it's not something you have to think about as much anymore. So they'd master it. Like, say they were, someone who went all day without eating and only had one big meal, and we're, working really hard towards sort of eating a little bit more frequently in smaller amounts. And they'd come in and get on the scale, and it wouldn't be where they wanted it to be, or they had have lost weight, but not as much. And they would say, okay, I've been working on this thing. I didn't see what I wanted to see, so I'm not going to work on that thing anymore. And so I would see these really amazing behavior changes kind of get thrown out the window because all they were focused on was that number. And so you can justify a lot of silly, crazy things to just hit a number, right? I mean, this is like wrestling or any of the, sports where the body weight kind of was monitored so closely like that. People would do all sorts of stuff to hit their goal weight. But this is such a different thing. It's lifelong, and all of those behavior changes stack up over time. And when you master one, you move on to another, and all of those are going to be the keystone kind of behaviors that are part of the thing that keeps you maintaining whatever, lower body weight or whatever after a period of time. And so that would probably be one of the biggest things I would say to focus on, is thinking about what are the things that you do to relate every day to your future goals and the future self, but not looking at just a number and not looking at just a weight. Because also the other piece of that is, when you focus just on a weight, what do you do when you get there, right? So you got to this goal weight. Well, how exciting is it for the rest of your life to defend a certain number and stay the same? Like, status quo as a goal sucks. that is not something that is exciting or moving you forward. Yet all of the other things that are behavior based are constantly evolving. I mean, think about athletes and fitness goals, right? Like, they're not talking about their weight necessarily. They're talking about, how can I reach, this peak performance? And so those are types of things that you can always improve on. And those are the the better types of goals that are going to move you towards a better outcome.
So basically what you're saying is the goal in total weight loss, other factors might include like being able to do a certain activity, or kind of like those non-scale victories, being able to feel more healthy. And I think too, I know with being in psychology and having that degree in your background, I feel like it's always how we feel in the moment, like really and truly how we feel. So, really, regardless of your weight, if you're feeling good, your health is improving in different ways. Is that what you're kind of saying here?
Yeah, those non-scale victories, I think those are all, I'm glad to see such a movement of people kind of figuring out what those are. One of the things I would always do would be, in the very beginning, when I first met someone, would be to talk about, what are the things that you want to do that you can't do now, or that are hard now, or that are uncomfortable now, and things that you're not doing because you're feeling limited. And those would be the things that I would really always pull out of my pocket when they would sort of be spiraling about a certain weight. Like, hold on. When we first talked, you said it wasn't about that. You wanted to get on the ground with your grandkids. That was always one that I heard a lot of. Or you wanted to, travel without having people like make you feel uncomfortable in airplane seats or roller coaster rides or things like that. These functional things that always were about feeling and always were about a response. They were not about a weight. And guess what? You're doing those things now. So if you're looking for a measure of success, that's a big one. That's a really important one. And I think that was an activity I think we used to have people do, would be to kind of list out, what are the things that you would define as things that you want to achieve. And they always were like really rich functional things. They'd have to do with people in their lives. They'd have to do with relationships. And really this whole, your worth is not defined by your weight. I think diving into that a little bit and what that really means. Like, you're not a good or bad person because of your weight. I mean, hopefully everybody knows that, but I don't think so. I think we really, we can beat ourselves up really bad when it comes to our weight, because everybody else is doing that. And that's where we tie in that whole weight bias and that whole internalizing weight bias. Some of the people who are the most, nastiest critics of other people about their size and their eating habits and all of that are people that are experiencing that themselves, because they've told themselves that for so long. And so I think that applies here too, which, really does come into unraveling a lot of stuff. So for me, getting a patient, a middle-aged patient who's been struggling with their weight and their health their whole life, there's a lot of stuff to unravel before we even kind of talk about the health improvements that they have from the surgery.
Yeah, absolutely. And I know when I worked with patients in the clinic setting before I worked with ProCare here, I feel like what you're saying, Nina, resonates with me. It resonates with all these other people. I know Aaron's saying, really enjoying this. I feel like you're speaking to me directly. I feel like people have weight loss surgery, and this sounds really funny, but not really to lose weight, but to feel better emotionally, to feel better mentally.
To be seen.
Yes, because think about how many people out there that are really, I want to say, overweight, that are happy, that are, healthy in different ways. And unless that bothers you emotionally and mentally, it's not a thing. So like, why should the world just puts a stigma on what we should look like and what we should dress like and all of that. For me, like one of the things I wanted was after having weight loss surgery, I wanted to be able to feel better in my clothes and that type of thing, and be able to dress
confident.
Feel more confidence. And, really it's not necessarily what I was wearing or what I was doing. It's like you said, having more confidence, feeling good in what I was wearing. Like, so it's not about the weight, really. I mean, when it comes down to it,
it's hard to get people to really embody that also, because there's so many messages from your healthcare team. Like you said, I don't think everybody knows this or feels this way. And I think there's a lot of places and programs that, I would say you don't know until you know, right? I look back at some of the cringy things that I would have said before I learned something. When I really got into weight bias, I was like, man, I probably did some harm in the way that I was talking to people and the way that I was, framing it. And so I think the best approach from a provider stance and from a patient stance is one of curiosity. And I think as the provider, I teach other healthcare providers, like they should be curious about their patient's experience. They should ask, them, like, what terms do they want to use to talk about their body size and their weight? They don't have to know them all. They just have to have that one-on-one with the patient. But then if you're the patient, I think you should also feel open to teach your providers about you, and you're the best person to know your own health. And so I think kind of on both sides, there's this sort of advocacy about our own health and how to get better. And so if your provider's sort of giving you the numbers game and saying, this is where you need to be, you could say, well, hey, these numbers actually don't end up helping me. I end up like really hyper focusing on them. And that kind of takes me away from what I'm here to do, which is to feel better and have more energy. And that is where I see, where I've seen body composition come into play as a nice outcome, because even if I want everyone to get into these like real soft skills, emotional type goals, people do like objective data and they do like outcomes. And we're talking about health and we're talking about health conditions. And so there are biometric parameters that can help you define where you're at from a health perspective. So I don't think we can get away from those 100%. But when you're looking at someone who's lost weight, and I know that, how far out from surgery are you, Brenda?
10 years. And actually that's playing right
10.
into this, Nina.
10.
Yes, 10 years. Actually a little over that, but like, I feel like you're playing right into what somebody's asking here. And yeah, those biomarkers, like I want to know what you're talking about here. Teresa asked, how do you add new measures of success once you've been at a stable lower weight? What questions should I ask myself? What could you use for measurements? So I absolutely love this, that you're bringing this up.
So I think, long term, again, you're not wanting to just look at the weight, but if you haven't been measuring sort of your body composition during the maybe more active early weight loss phase, it's a good time to start. I mean, my vision long term is that every primary care doctor's office would be using a measurement of body composition every year for their clients. So it would just be like, here's your blood pressure, here's your lab work, here's what your body composition is. Because outside of even a weight loss, obesity care, bariatric perspective, we want to look at people's muscle mass over time, because low muscle mass is related to all sorts of negative health outcomes in an aging population, which we all are. So, and I think with 80% female population having bariatric surgery, we're especially needing to be in tune to what are some of the dangers, or maybe dangers is not the right word, but what are some of the, potential negative outcomes from not having enough muscle mass. And there's, frailty and falls and sarcopenia, which is a word just meaning like low muscle mass. But the more I dive into this research, the more like surprising it is that maybe we don't even need to be focusing on body fat as much as we do as preserving or increasing muscle mass. And that has a lot to do in this particular patient population with long-term. So long-term patients like you, 10 years post-op, what does your muscle mass look like? And if someone loses a lot of skeletal muscle mass during that active weight loss phase, it's going to make it harder actually to keep the weight off. So one of the things that's kind of interesting, and I know people always talk about metabolism. It's kind of a complicated subject, but when you're looking at your resting metabolic rate, so the kind of number of calories that your body's burning at rest, that's an important number, not because I think we need to be focused on calories or calorie counting, but how much your body's burning at rest is an important number, because if you're losing weight, the smaller your body gets, the less amount of calories you need to sustain that body frame, right? And if you're losing a lot of muscle mass, the muscle is what is your kind of your engine to be burning more calories. So if you look at two people, one lost a significant amount of muscle and one lost body fat but kept their muscle, even if they're the same weight, the person with the higher muscle mass is going to be burning more calories at rest. That's important once you've reached that low point of your weight loss, because you're not going to be able to eat as much if that's been driven down too much. We've seen that in the Biggest Loser studies that they've done. People who've lost enough and can only eat 800 calories a day to keep their weight where it's at, which is unreasonable for those folks. So that is really directly related to your muscle mass. And that's something that body composition devices, bioimpedance is the technology that we use. So if you guys have seen those types of devices, they look just like a scale. Ours is nice and it's German engineering. It's really kind of fancy and nice looking, but you stand on there, you hold your hands on the handrail, take your shoes off, and it's running a low electrical current through the body tissues. And when it does that, we've been able to differentiate using, I don't do that part, the formulas of, this is how fast it goes through muscle and water, and this is how fast it goes through body fat. And they're able to have these prediction equations validated to these other gold standard measures. So for muscle mass and for visceral adipose tissue, doing an MRI is actually the best way to measure that. But you're not going to go get an MRI every 6 months. So what we do is we do the bioimpedance technology, validate it with the MRI, and they're 98% in agreement or 98% accurate. And so I think most of us would agree 98% is pretty good, and good enough to sort of stand on a device in a clinic without your shoes and not have to go get an MRI. And so what that tells you then is how much skeletal muscle mass you're able that you have. It also breaks out what your body fat would be, and then there's several other parameters that you can look at, things like visceral adipose tissue. So that's a big word, but basically that means the fat around your organs, which is the much more unhealthy type of fat for your heart and for your other health conditions. And that's a metric that I think we're seeing more and more people measuring, because it really takes away this arbitrariness of a total body weight, and it brings it towards, well, why do we care about excess body weight being a health condition or a health risk? Well, we're relating that to your cardiometabolic outcomes. How are you, heart attack risk and, some of these other diabetes risk, right? So if we're able to give you a measurement around waist circumference, right? That's one way. And that gets involved in the algorithms for predicting visceral adipose tissue. Those are actually measures now that we're really connecting to the health condition. So it's not arbitrary. It's more personalized to this individual. You're not just saying, oh, here's a weight of your bones, your muscle, your water, and your body fat. This is what your precise measurement is. And here's where that can be linked to some health conditions. So I think it's also, for the patient, it's a much more individualized assessment. And then you can track and see changes in those numbers, because we've all had the weight not go the direction you want. And that's one number. And that's very derailing. But if you had 5 or 6 other numbers that you're tracking and you're saying, okay, it's an experiment, right? Like, I'm changing this and I'm seeing some changes here. Okay, that's great. But it's really hard to just sort of trace that number when you're just looking at, oh, well, it could be water weight, and, oh, I didn't go to the bathroom first. And it's this mind game, and it's the cycle. And I think, having that be something that you do daily at home or multiple times a day is truly the opposite of what you're wanting to focus on, which is those actual daily behaviors that you have control over.
And I think too, it plays into, when people get further out, like say you're a year out or 2 years or 3 years, and a lot of times people will focus on having plastic surgery because of the excess skin. Maybe if we were more focused on the amount of protein, the amount of like special foods to build that muscle, like to be able to have more definition. And I'm not saying that would change everything, but it might change some things a little bit, like as far as your body tone and all that. I heard something yesterday and I just had to laugh. Like I don't know if it was on Facebook or what. They're now saying like a lot of these GLP-1 medicines, which a lot of the people in the bariatric community are on now, after being on them for a while, are having what they called Ozempic butt. So I had to open up the article and I had to read it. I'm like, what is this? And why would you say that? I think it just has to do with, rapid weight loss, and then seeing, not nutritionally, not being able to, like, you're not eating maybe the amounts of protein and building muscle and that type of thing. So maybe you see like in your face and the butt area.
Yeah, there's a lot to unpack there. I think, one of my big frustrations with the way the media has presented a lot of the outcomes in the conversation around the anti-obesity medications or the GLP-1s or semaglutides, and is that, part of it is it's finally getting attention of the media because it's beyond this tiny little niche group of surgery, right? So like, I'm sure patients would say there always was bariatric butt or something, right?
Yeah.
Like, there's when you're losing body weight a significant amount during a short period of time, that is what you're seeing. Is we don't get to pick where it comes from, and if you're not balancing that out with a good amount of protein, and then I would say even more important would be that resistance or strength training. That's hard to do during that time. And so if you're not balancing that out, you can see changes in the body that are not desirable. But the fact that that's newsworthy is again, I think part of the media is sort of looking for negatives about something. And also there's a lot of people that are taking medications that may be on the much more low end of needing to lose weight, where maybe they only are needing to lose 10 or 15 pounds and somehow they got on this medication. So they may be losing it in a different way because the studies maybe didn't include people at those low weights. So there's a lot to say there, but I do think, the take home for me would be, okay, well, how for someone to go from where they were at to a noticeable change in their butt or their face, I would say there's a lot of time points in between there that we could have had an intervention. So if you were going to a clinic that had a measurement tool for you to see, okay, here's my muscle mass. Wow. Now, am I losing it too fast? And you're able to see that. Well, there's a way to intervene. And especially if you're on a medication, you could taper down the dosage and all of that, intervene way before you get to, I mean, are we really going by looks now? And like, oh, you don't look good. That's an assessment. Now go see a plastic surgeon, right? Like, isn't that crazy? So it's so not objective.
It's so,
when you're getting to a
so
point
I'm wondering, like, why would, for one thing, I know with working with patients, and I know you've probably heard this a lot before, but a lot of times people, one of the reasons for being scared about having weight loss surgery is having, quote, sagging skin. To me, like in my thought process is, wouldn't you feel better still? Wouldn't you, I mean, to me, people, even if they have sagging skin, maybe they have a more confidence about them. They're lighter. They're able to move easier. So like when you think about that, I don't know. It just, sometimes I'm like, I don't really see that as such a negative. Like I guess everybody's opinions are different, but
I take that all as data points and learning about a patient, right? So I think that everything that people say is important in thinking about what matters to them, right? So if we're hearing skin aesthetics and something like that is maybe more important to someone, I would say that would be a reason to maybe tailor what they're doing. And like you said, do more protein, do more resistance training to defend that. If that's their goal is to not have that. Some of that's inevitable based on your biology. And I used to talk to patients and say, like, how did you do for the women who had kids? Like, how did your skin respond after, making room for a baby? That probably was more predictive of how they were going to do after surgery and how long they were carrying excess weight, right? Someone who's had that since they were a kid is different than someone who post-menopause had body changes. So there was so much involved in that, but I do think it's important. I think every conversation is a chance to like get to know the patient and what their goals are. So I do remember that being a focus. And I remember people's answers being like, well, you should care more about your heart than, what you look like. And I don't agree with that. I think it's all important, and what people are telling you is important to them are factors. So everybody's going to have different goals. And that's, again, we've got to personalize this treatment. And I think having better ways to assess response to treatment is in line with what we're moving towards in healthcare is, more precision, more personalized medicine.
Yeah. So tell me, like, when we're going back to the biometrics and what's being measured with some of this equipment, and how could you, like, with the things that are being measured, how could you use that to be able to determine first of all, do you have parameters that you kind of look at and say, this is what is more ideal, or do you even go there? And also, how do you use that to be able to change regimens? And I know that's not probably seca's what they do. They don't tell people, what they need to do. But from a dietitian standpoint, maybe if you could add a little something, like how could you use the information? What kind of information are you looking for? And then how do you put that into play in an everyday lifestyle?
Yeah. So, I mean, you're looking at kind of some of these parameters all together. So you're looking at a couple different ways to measure, body fat, the body fat percentage, the pounds of body fat, the visceral adipose tissue, right? So those are some of the measures for that category. You're looking at skeletal muscle mass, sometimes skeletal muscle mass as you age, in different segments. So you're also able to see in your arms and your legs where the muscle is. So that could be a way to sort of see, are there different parts of the body that are more developed or underdeveloped than others? There's also parameters in total body water and the ratio of your extracellular to your total body water. So these are also indicative of, people who have more muscle mass have more intracellular water, and those patients would have more total body water. So there's parameters that you would look at like that would say, these are all kind of coming together to say, oh, you've got some pretty good muscle mass. And a lot of people who live with obesity have pretty good muscle mass because they're carrying around extra weight, and that does develop muscle over time. So what's good about that, if you're someone who's got a high muscle and a high body fat and high skeletal muscle, is that when you're losing weight, you're not worried about necessarily building muscle. You're worried about preserving the loss. And so you can kind of see as one's coming down, we're trying to keep that other one stable. So that would be a parameter I would look at. You have patients who their total body weight is high, their body fat is high, but their muscle is really low. So if that was a patient prior to surgery, I would really focus on getting their protein intake up, getting their resistance up before they even had surgery, because we know that this is going to be the course, and it's going to be much harder afterwards. So that sarcopenia that I said, low muscle mass, can also be seen in someone who's got a high body fat and a high weight. So that's associated with its own kind of series of negative health conditions. So those would be some things to look at. And then some of the other muscle mass parameters, there's one called phase angle, and phase angle is a lot more complicated, but that has a little bit more to do with the integrity of your cells in your body. And that can be related to overall health. And if that's really low, that's associated with malnutrition and some other things. So that's something kind of interesting to look at. And then that resting metabolic rate that I said, we have a calculation that integrates the body fat and the muscle mass, not just total body weight. So it's better than a predictive formula. And that's another one that you can see changing as someone's, the numbers are trending after surgery. So a waist circumference, we have people measure the waist circumference, and then that gets entered into the device, and the algorithm will include that waist circumference for visceral adipose tissue. Those are other ones that you'll see changing. So I think having, I think probably about 5, 6, 7 of these parameters to focus on, not too many, right? Because sometimes too much data is too much. And I also think this brings up a little bit of a point of like what people are measuring back at home. So there are some like over-the-counter devices people have that measure their, or that say they measure their body fat, or a couple parameters. They're not going to be as accurate. They're not going to be as comprehensive, because they're not able to measure some of these things. They're also usually foot to foot, so you're only getting the bioimpedance through the bottom half of the body. So these are tools that people want to make a at-home device so that they can measure those numbers more frequently. I sometimes think I wouldn't want my patients to have access to too many data points every day, because what is that actually translating to for health, right? If you're following these numbers, and then you have a whole new series of numbers to get obsessed about, right? So I'm always thinking, how is this translating to what you can do? And so as you asked sort of what would be the advice from a nutrition perspective, it would be really kind of looking at the quality of the protein in the diet, how it's spaced out throughout the day. Are you able to get it in? There's different, guidelines, and probably Kim, who you had on last week, would be one of the experts in, building muscle from an athletic perspective. But yeah, kind of spacing that out throughout the day. Is there a need for a supplement? Are there foods in the diet that are not contributing as much nutritional value that we can pull back on to make room for some of the proteins? I also find that, again, I know people talk a lot about protein, but I think some of the solid protein foods that you have to chew that make you feel fuller longer, end up being good choices for other reasons, and satiety, and, like getting your total intake to be a little bit lower because you're feeling fuller longer on a smaller amount of food. So I think there's some ways to integrate those results nicely into the clinical practice.
Wow, I think you answered a lot of the questions, and kind of tying things up. How would you summarize all this, and then tell us how they can kind of contact you or get more information? How do they find a clinic that has these products, or can they recommend, ask their physicians about this? Kind of ending points, and then also
Sure,
your contact.
Yeah. So I would summarize it. I guess I would say there's encouraging news from the field in that the healthcare providers are kind of all working together to come to some better consensus about defining the disease, the long-term chronic disease state of obesity. So kind of look for that, coming forward in the next couple of years, as they're getting away from measuring weight and BMI and going towards more precise or, precision, personalized medicine. You'll see more maybe adjusted BMI, adjusted waist circumference, things like that. You'll see hopefully body composition in more than just a bariatric clinic, but in a primary care office, in a YMCA, in other kind of places that are out there in the community. So hopefully kind of networking that together. I think looking at just the nice thing from my perspective with body composition assessment using bioimpedance is that it's an easy way in a clinic setting that you can just get some new data points, and you're measuring as someone's coming in to see what is changing. And then we let the clinician sort of deal with those recommendations with you. So, but right now, there's a lot of talk out there, like you said, with the GLP-1 medication class about weight, where that weight is coming from. The problem I'm seeing is we're talking about it in a speculation, but we're not seeing people actually measure it. So I would say if you're someone who is prescribing medication or performing surgery, it's the responsible thing to do to assess where that weight loss is coming from so that you know when it's time to intervene if it's going off the rails. And I would say as an individual, thinking about your muscle mass, your muscle tone, what you're doing to keep that up, not just doing exercise just because that could be a whole nother topic, but maybe including some strength training and resistance training to your regimen for the purpose of protecting that muscle during active weight loss. And then for the long-term and the maintenance phase, I would say, if your clinic does not have a body composition device, you can certainly give them my information. but I think it's important for people to hear from the patient of like, hey, this isn't this, like I said earlier, you've got to advocate, like this number's not enough. I need to know, where my weight loss is coming from. And I think people, they'll respond to the patient. And it's a good time, I think, to be a patient right now. Providers are listening. They want to keep you as a patient, and they want to hopefully keep you satisfied. So I do think asking for that is a good idea. And then, staying in touch with me. I'm now on LinkedIn quite a bit, so happy to connect with anybody on there. That's just on my name, Nina Crowley. I'm on Instagram, and Twitter's fun for a lot of like professional meetings and kind of news stories and results too. So I'm on there as Dietitian, and Facebook. Where else? Or seca has a lot of accounts too. So the seca Medical Body Composition North America Instagram page is a patient kind of page they could go to there and see what the devices that I'm talking about look like. And then just by email. So nina.crowley@seca.com. If you want to reach out or connect that way is fine too.
I just posted, Nina. I just am posting your social contacts. I had written down kind of ahead of time just to have those kind of ready to be able to post. So I just posted your LinkedIn, your Twitter, your Instagram, and your Facebook links so that they have those. As far as your email, I may also be able to just copy that. I thought I had it, but...
Just nina.crowley@seca.com.
Okay. I was going to type it out for him. nina.crowley@seca.com.
.com.
That's easy. I put an extra N here, but you guys know here. seca.com instead of COMM. And I'll copy that over to Facebook too so that they have it as well. Any other closing thoughts?
Oh, just happy to have the chance to talk to folks. And really, I do highly recommend coming to the Obesity Action Coalition's annual meeting. I've been involved on the board of directors and have some sneak peeks at the talks and the topics and the programming this year. And there's some really cool stuff that they're doing. Really interactive, engaging. I mean, I think that's one of the most, I go to a lot of professional meetings, and I think this is one of the most high caliber meetings for all healthcare professionals to go to. So I'm a big fan. I think that'll be really great.
It looks like Victoria's had a couple comments here to kind of add to that.
I'm just peeking at those now.
Yes.
I'll see you there. If she's headed to the OAC meeting, I'll be there. Excited to see you.
And the OAC too, I know you mentioned professionals, but there's a lot of patients there, wouldn't you say?
Oh, it's a patient group. Yeah. I just mentioned, like, it's not just like they're throwing together an agenda and kind of, showing up there. It's, I would say, even more professional than a lot of the healthcare professional meetings that I'm at with, really nationally known speakers, but all ones that are really engaging and connected, and they want to be there. So it's really cool. It's a great experience if you haven't been, and if you haven't been lately, they're doing some cool stuff. It's in Orlando. So I think it's a family friendly place. So it'll be great. So hopefully you can meet anybody there. Please reach out.
And absolutely. It also looks like too, if you can't make the on person, I'm going to actually share my screen here real quick, just because I think it's great. I also want to say, I'm going to share my screen and show them the website, but I also want to say Victoria added to what you were saying earlier. And I think it's just really relevant to bring up. She's 10 and a half years post-op from VSG, and she said she's working through her third weight reoccurrence, and focus is different this time. Data points I'm tracking is movement, mobility, quality sleep, vitamin supplementation, and hydration. Never felt healthier, and with a higher BMI. Shows me that the scale is not always just the big indicator of where you are with a lot of those things. It does make a difference, with all of that. And I'm going to share my screen real quick, Nina. I hope it's okay. That's my notes.
Yeah.
Apologize about that. Here is the Your Weight Matters, the OAC page that I had linked to earlier. And there's actually a in-person event, which if you go over to Engage and you look down, and it'll have all the information that we were just talking about, but there's also a virtual. So is there anything you want to say about that too?
Yeah, the virtual was in April. So they've been trying some different formats since COVID, to engage people sort of from home and people who aren't able to or don't want to travel. They had a really great meeting in April. A lot of that content is still available, and they've just in general got a lot of great content on their website. So I think that's a great place to check it out. But I don't know how you feel about in-person support groups and all of that too, but I just think that there is something really valuable about a bunch of people sharing an experience who kind of have some common background in some way. It kind of feels like not college, but in a way where you have this experience that you can't replicate college to me, fully online and have that same connection with people. And so the people that I've met at these meetings have remained great friends, colleagues, and you see that amongst patient to patient too, and patient to healthcare providers. So it's nice for healthcare providers to, I think, see and interact with patients that aren't their patients, right? Because it just gives you a bigger and more rich experience of the people that we're all doing this work to help and facilitate change in their health.
So, so true. I get 10 times more, I think, out of just being in person and being able to connect with people, actually talk to people. I think that's probably where you and I have met before in the past. I'm trying to think of how many different conferences, but I'm sure, I know that the OAC conference last year was one of them, and that we'll be actually together here real soon. with this one because I get to see you again on there.
Yeah. I'm
think
excited for it.
I think too, I'm going to stop sharing that for just a second. I actually think, Nina, I might even have you. We actually just announced here recently something called Very Connected, which is our platform, which is what this is being hosted on. So basically, we take these and we put them onto our podcast, Very Connected. So if you're listening, if you want to listen on any kind of major platform, I love listening while I'm on the road and that type of thing. So it's a great way to listen. And we're also putting these on our YouTube channel. I'm going to share because I'm going to surprise you. You don't even know this, but I'm going to share something with you. But here on our Very Connected page on our ProCare Health website, you just go to procarenow.com. We actually have our new information here on our site. And look who's here. Can you see?
Oh, that's us. And Sarah, look at that. Yeah, so that was the Vegas meeting, huh?
I just had to show that to you. I figured you probably hadn't seen it yet, but I just had to share it.
No, I haven't. That's cute. Hey, I'm happy. And I'm like that excited all the time for this
I know
topic,
you are. So. That's why I'm like, I got to put Nina on. I picked out some of my favorite pictures. These were pictures I sent to our marketing team and they put them on there. So I just had to share that with you that you're on our website.
That's awesome. Oh, cool. Well, yes. I'm proudly there. Being your cheerleader.
You are being my cheerleader. And up here under Very Connected, guys, that's where I was going. At the top tab on the ProCare Health website, if you go over here to Very Connected. And I wanted to also share too, because all of these are on replay. So they will be on replay till the end of the month. So we're getting close, 7/31. All of our weekly events, you can scroll through. There's a little tab button. It's kind of hard to see. Here's our one today. So if you decide you want to come back and listen to this again to kind of get some pointers, I like listening to things sometimes a couple times for things to kind of really sink in, integrate, kind of understand fully. Or maybe there's things I get like while I'm listening, sometimes I'm like, I get a thought process that goes one way because I'm like thinking about what something said and then it's like I missed something. So sometimes coming back and like being able to listen is a great way to do that. We're also putting things.
That's great.
Yeah. We're also putting things on our, we have monthly support groups. So you can still listen to that to the end of the month. We just had that last week. Our podcast, how to get on there. And then our YouTube channel, which I'll just pop on and I'll show them real quickly. Our ProCare Health YouTube channel is ProCare Health Vitamins and Supplements. And so before we end, we've also been doing a special little promo with a product. The product promo that I kind of want to bring up today, I'm going to pull up a picture here. And so I'm pulling up actually the solution instead of the problem, but let me go back, see if it'll let me because I got to go full screen here.
I like the look of all this. This is really nice.
We're talking about insulin resistance. So that was actually the hype around insulin resistance. Thank you for saying that. Our marketing team helps us with different things. And how do you know if you're insulin resistant? No one test will tell you, but your risk factors may include like high blood sugar levels. And we were talking about this earlier, so it kind of just fits in. High triglycerides, high LDL, low HDL, family history of diabetes, being overweight, especially around the waistline or being inactive. And I'm going to pull up one more graphic. One thing that people can do is, I thought I had it here. Here it is, some things that you do in your lifestyle. And we've talked about these things here. Exercise can be one of the most fast, effective ways to reverse insulin resistance. And so when we're talking about that, you were talking about some of those things about resistance training, different kinds of physical activity, eating a balanced diet, fruits, vegetables, proteins, low fat. So there's lots of things you can do besides just taking medications. Moderating your carb intake can help with weight loss, but also helping decrease insulin resistance, and then supplements that support that. And ProCare does have a supplement we just came out with. I'm going to highlight that really quickly here. I had it pulled up. It's on our website. It is a product. Let me pull up the actual front of it. Insulin resistance support. It just kind of came out. And basically, what this is a product that it can help people who are feeling like maybe they're having some insulin resistance issues. Now, if you're on one of the medications, like we talked about, a GLP-1, which I know Nina mentioned some of those different things like Ozempic, Mounjaro, there's a bunch of different ones. If you're on something like that, it can help support you. It doesn't necessarily, it can be something okay to take along with that. Or if you're on metformin, it's something that can be, I'm going to copy the link and I'll share it here in just a second. It is actually on our website here under products and under therapeutics, and it's on page 2 under therapeutics. I'm going to stop sharing because I also have, actually, you know what? Let me share one more graphic, which is kind of a fun little thing that my coworker, Erin, just showed with me right before we started. She said when we developed this product, we developed with a physician, and he said that the main things that, like when you're looking at GLP-1 medications and that type of thing, a lot of times they will support in different ways. And so each of the ingredients that we put in this insulin support actually acts upon different ways to support you in the ways that that medication will support you, or your metformin will support you. So each of those is the magnesium, chromium, berberine, I hope I'm pronouncing that right, turmeric, ALA, cinnamon bark, green tea, resveratrol. Can you help me there, Nina?
Resveratrol.
Thank you. And Vandium. So all of these are in the new insulin medication that I just mentioned. And I'll put the link out there if any of you want to check out that a little further. Again, it is safe to take if you're on one of those other medications. I believe she said that the physician they were working with was a Dr. Jeff Hendricks, who helped us develop the formula. So it's basically a holistic supplement that mimics how those shots affect the body. I'll paste the link. Anything you want to say on that, just from a dietitian standpoint?
I couldn't see it very closely, so I'd have to do my true type A dietitian thing and get involved in the research behind it before I made a comment.
Yeah.
But yeah, it is, I guess what I would say is, when I got into bariatrics, it was 2006 or 7, and there was like Citracal was your calcium supplement, and there were not very many bariatric specific vitamins. So it's been, talk about a real improvement in one area. This vitamin kind of pipeline has really improved, and it's been really exciting to see what options we have for patients to stay on their vitamins long term. I think that's really cool.
You know what? Thank you for saying that. I know I kind of feel like the same way. It's like there's, from a standpoint of being in a bariatric clinic over the last, I guess I've worked in the field probably since 2012, so about 11 years, and just seeing the transition of the different kinds of products. Bariatric multivitamins and calcium supplementation was some of the first things that kind of like were really one of the big things that they were kind of putting out for patients and recommending, because, your needs are special if you are a bariatric surgery patient. But then seeing all the different additions like to support. Yeah. There's so many more, and it can be a little overwhelming. Even coming onto this call today, this is one of our newer products, and so I kind of had to do some research trying to figure out exactly what we're looking at and understanding it more fully and why patients are interested. There is one Q&A question that we're going to take real quickly here before we jump off, and it's an anonymous question, but just says, when working with a therapist, what sort of conversations should be had around weight loss, current and ongoing?
That's a good one. I would say, again, from a curiosity standpoint, I would kind of find out what they know about patients who've had weight loss surgery, or, who are struggled with their weight. I wouldn't assume that they have had that experience. There's a lot of people, I've encountered over the years who really don't have that specialized skill set. So if you're interviewing and trying to find someone new, I think that would be an important thing to ask. It's I think as we see more people taking medication too, the medication community has never really been, like the bariatric community has been really centralized around the surgeon, the team they built out, and support groups and all of that. And I think that I hope that we can take what we've learned that worked well in that to the medication world. But I think there's going to be a lot more people who are just getting medication, maybe from a primary care provider, that don't have access to, or they don't even know they need it yet. Full, the specialists do, right? But we have to work to educate our primary care colleagues to say we need an interdisciplinary team with the dietitians, with behavioral health, with exercise, with all of those other interdisciplinary people on the team. So I do think if you got a therapist you're working with, talking to them about, how, just diving into a little bit how weight has impacted all the different areas of your life, I think that is definitely important information to have those conversations about, but also being clear maybe that you're not looking for advice on changing that. You're more looking for advice on how to stay connected to the behavioral changes rather than the outcomes. That's really the take home, I think, for a lot of these kind of consultative type connection conversations.
I think that's a great point, Nina, because it's just like if you have heart problems, you see a cardiovascular doctor. If you have lung problems, you see a respiratory specialist. Not all therapists study the same things, and not all of them are focused in the same areas. Some might really focus on anxiety or depression. So not that a person who's going through weight loss surgery might not have those things, but I think having a perspective of maybe having cared for some patients that have dealt with obesity problems might be helpful, because that might be some of the questions that you may be interested in kind of, digging into, especially if you're undergoing weight loss surgery. So thank you for that. That's great insight. I think that's everything we have. So thank you so much from the bottom of my heart, and look forward to seeing you. And hopefully we'll see some of these people on this call. Come up, introduce yourselves to both Nina and I.
We'll have our device there, and we're going to be doing a special kind of area for screening. And so we'll have even some one-on-one time if you're there at the meeting.
Oh, awesome. You mean they can actually stand on your scale and get like a reading?
Yeah. For
free, or
Absolutely.
Is there a cost to that for them to do that?
I mean, the cost is you have to talk to me for a couple minutes. So no, I'm excited for being at that meeting as a exhibitor this year. So
that is awesome. It looks like there was a question about email, so I'm putting mine. I have Nina's up listed in the chat box above. So in case anybody wants to reach out to her, make sure you just use one M though. And Nina, I look forward to seeing you in person. I'm going to be reaching out to you through email. Thank you so much, everybody, for everything here, and have a great week. Enjoy. We're halfway through.
Great.
We're on hump
Thanks,
day.
Brenda.
Bye, everybody. Thank you.